here we're going to go through the most common causes of hip pain. So the first one is osteoarthritis, or OA. It's a degenerative condition. It's caused by mechanical overload by a weight-bearing joint. So it's not just the hip that can do this. There's other joints that can do this, but we're specifically talking about the hip today. It mainly affects the articular cartilage of the joint. So that's kind of like what lines that socket, okay, or that femur head. But it can affect the underlying subchondral bone, the synovium, and the ligaments in the joint capsule can get affected as well. So what happens is that, you know, that lining, over time, it gets like some wear and tear, it gets broken down, right? So there can become some fissuring or pitting, and it actually erodes that articular cartilage, and that's what causes all the pain, okay? It leads to, over time, that's kind of with early arthritis. After it progresses, there gets to be some thickening and sclerosis or inflammation of that subchondral bone. And then this can further lead to decrease of shock absorption and lubrication. So it gets dried out in there, and it's just old and cranky, right? So, you know, after you lose that function, then, you know, there's bone-on-bone activity, and there's leads to a bit of an instability, and it forms what we call an osteophyte. So that's like a little bony spur, right? And that can, just think about if it's grinding or rubbing on each other over time, that spur is going to build up, and that's maybe sometimes when people that were saying you get that catching or that locking, that can be from that sometimes. So, you know, some risk factors with OA is obviously it's a weight-bearing thing, right? So if we have more weight to lug around, like if we're, you know, put on a few pounds from the holidays, as many of us have, or obesity, that kind of thing, that can put you at further risk for arthritis. If you have some muscle imbalances, like we talked about, or weakness. And then those of us that, you know, with our daily activities or occupations, if we're repetitively loading those joints, but actually the worst one, more than just loading it, is inactivity or sedentary. So if you're not doing anything, that's actually worse than if you were to, you know, be doing activity. Okay. The second one is greater trochanteric pain syndrome. So this one, it arises from the pathology of the bursa and the tendons. We used to think it was actually just from a compressive friction and inflammation of the trochanteric bursa, which you see, it's that little purple one right in there. That's the one that kind of gets compressed. That's what we used to think caused all the pain and stuff there. However, now it's more, you know, it's better understood that most cases of trochanteric pain, they demonstrate some evidence of gluteal tendinopathy. So it's not just the bursa, it's actually the glute-med and glute-min muscles, the tendons that run over top of it. They get broken down over time, and they can't handle those loads anymore. So, you know, the bursa may be involved, but it's not without the glute-med or glute-min tendons being affected. So that's, you know, that's where a lot of that pain comes from, is a tendinopathy. Okay. So with tendinopathies, you know, they can range from severity. You know, it can be small little micro traumas that you wouldn't even be able to pick up, or, you know, there's just little aggravation, to a full grade 3 tear where it's fully torn off the bone, right? So there's variations, and then anywhere in between that, okay? So, you know, where those tendons insert on the greater trochanter there and the IT band, again, the bursa is vulnerable to the compression and the friction by the overlying tendons in the IT band. So those of you that they said they had some snapping earlier, this is a kind of a clue for you guys. If you have that audible snapping in the hip, it's basically the IT band is running over that greater trochanter and snapping over that. You know, if you have that in the outside of the leg, from when you move from that, when you move from an extension to flexion position, it will snap over that sometimes. So those of you that had some walking or running kind of things, or skiing for that matter, those kind of things. So over time, those tendons, they get broken down. They can't handle that normal force or that excessive load anymore. And then they get weak, and then lead to dysfunction like we talked about already, okay? All right, the next two. Femoral acetabular impingement. This is a condition that occurs where there's abnormal contact between the femur and the acetabular rim. So again, that ball and socket, okay? So there's two types, well, three types, but you can have what's called a cam impingement, or this is an abnormality on the head or neck of the femur. So you can see that middle picture where there's a bit of that osteophyte or that bony spur that forms right there after, if it's wearing on that other spot, right? You have a pincer impingement. So this is an overcoverage of the femoral head by the acetabulum. So you can see that socket itself is actually extended over top, and that's where it kind of gets that pinchy sensation on. But you know what? Most of the times it's a bit of a combined nature, which you can see on the right picture. It's a little bit of both, just because they wear and rub on each other, right? So they, over time, the bone will adapt and form those little spurs or osteophytes on both of them. It's caused, like I say, by that reoccurring impingement between the acetabulum and the femur. And it's basically due from repetitive micro trauma, and especially with the movement that you really notice with this one is when you're bringing your knee or your hip into flexion and then internally rotating it or getting it up into that position. That's where it really usually pinches on a lot of people's hips if this is kind of a condition for you. And furthermore, after a while, it can lead to damage to the labrum, which is basically like your shock absorber and the articular cartilage, and then it can get you, it can result in early osteoarthritis. So some of the contributing factors for femoral acetabular impingement are that Trendelenburg or that coccyx valgus, that excessive hip adduction that we talked about earlier. So that can lead you to some of these this disorder. If you've had any previous femoral neck fractures, if you had like that retroversion or anteroversion where the hip's sitting forward or backward, that can lead to some of this. And then sometimes with those of us that have had childhood hip conditions like Perth's or slip capital femoral epiphysis, those can often lead to these kind of issues later down the road as well. And then it's not following that centered path. It's hitting instead of staying centered in that joint like we talked about. And then it forms an imbalance due to the dominance of the TFL over the iliopsoas or hip flexors. So the last one I want to talk about is radiculopathy or lumbar referral. So this can be caused from damage and irritation of the lumbar joints. And it often will refer into the hips and legs as well as the back itself. So which joints, you have 5 joints in the low back, and which joints are affected will kind of determine where the referral pain is felt. So you can kind of look at the picture there for yourself. It's quite variable. It can go into the groin, it can go into the buttock, the back, down the legs, or into the lateral or hip or front of the hip. So it kind of depends where those joints are getting compressed. So what a radiculopathy really is it's where a spinal nerve comes out of the lumbar spine, and it experiences a loss of conduction. So think about it, those of you that know a little bit about wiring or about electricians or those kind of things, it compresses it and it causes a loss of conduction. So it can cause you, there's basically 2 branches that come out. One's a sensory, so that's everything to do with feeling or touch. Sometimes you might lose feeling, or you might get some sensation changes, or you might not be able to feel some things that, and the other is a motor one. So if there's some weakness, that motor branch can be involved. But you don't necessarily have to have pain. There can be, but you don't necessarily have to have pain to have a lumbar radiculopathy. And usually it's from a compression or inflammation is the most common. And the most common kind of injuries here are if disc herniation, if there's the osteophyte on the spine, or spinal stenosis as well. And like I said, patient symptoms can vary on location. with most commonly the L4, 5, and S1. About 90% of the time, it will be from those areas.